Okay. So, for today's topic, our resource person is Dr. Bablesh Mahavar. Dr. Bablesh Mahavar, ma'am, has an experience of more than 17 years, has been an interventional pain management consultant with experience in chronic pain, cancer pain, and palliative care for more than 9 years. Madam was felicitated by Dr. Harshvardhan for contributing a chapter on cancer survivorship and palliative care in a book of surgical oncology, Devita Hellman Rosenberg. Ma'am organized the National Pain Conference, PainCon at RGCI, 2 consecutive years, 2018 and 19, and also palliative care workshop in RGCon 2019. Ma'am has conducted several CMEs, CNEs in pain management and palliative care, educational programs at Delhi AHA certified BLS and ACLS training as a lead instructor. Dr. Bablesh started the Prayas series to spread awareness on cancer pain and supportive care, has numerous publications in various national and international journals. Ma'am has also contributed a chapter on pain and palliative care management in a book on head and neck cancer and has delivered faculty guest lectures at various conferences and workshops. Numerous awards to her name as well: Best Poster Award at Indian Pain Update, Best Poster Award in International Conference in Recent Studies in Pain, and Best Presentation Award in International Conference in Study of Pain 2019. I welcome you, ma'am, to deliver a talk on a very important topic, that is the applications of CT in cancer pain. Over to you, ma'am.
Thank you so much, Dr. Javed, for such a kind words. So, shall I share my screen now?
Yes, please. Visible, ma'am.
Is it full screen or is it half
Yes, full
screen?
screen. Full screen.
Full screen.
Yeah.
Okay. So, good evening, everyone, and I welcome you all on something neglected but still an important topic in cancer pain management. That is the role of CT, safety, precision, and best practices. So, I have nothing to disclose. Now, why we are here and we are talking about cancer pain? Because in India, more than 1 million new cases of cancer are diagnosed each year, and it is estimated that the cancer burden in India will almost get double during the coming 20 years. And pain is almost the first symptom in advanced cancer, and it is an independent predictor for poorer survival. There are other poor prognostic features as perineural invasion, lymph node metastasis, which are also associated with increased pain. So that is why, just to tackle this pain, because just believe me that the management of cancer pain and chronic pain is entirely different and it is a totally different ballgame. So, cancer pain can arise, as we all know, that it can be because of the tumor, because of the treatment the patient receive in the form of chemotherapy, in the form of surgery, in the form of radiation therapy, and certain other complications linked to chemotherapy and radiation. For example, the chemo-related peripheral neuropathy. So, pain can be acute, chronic, or breakthrough and can severely impact the quality of life of patients. Importance of accurate diagnosis and effective management is very, very important in these patients. So now coming to one of the fact that the number of interventional pain procedures performed annually has increased over the past 20 years, much of which can be attributed to the advancements in imaging technology. Now, why CT? Why we are talking about CT today? Because almost every time we talk about fluoro, we talk about MSK, ultrasound guided blocks, but we never talk most of the time about CT. Because mostly the cancer pain management is, as I told you, different from the spine pain management. And why we are talking about CT today is because it helps in improved diagnosis, enhance the precision and accuracy, pinpoint the cancer related pain sources, and it is the cutting edge tool for early detection and tailored therapy for better outcomes. So CT ensures the target area is reached effectively while minimizing the damage to the healthy surrounding tissues and reducing complication risk. It improves the needle placement and accuracy by showing the exact spatial relationship of critical structures, and it may maximize the therapeutic efficacy in complex visceral pain procedures as well. So it provides the detailed three-dimensional anatomical information, eliminate the problem of overlapping structures, a major limitation in the 2D images produced by fluoroscopy, and the detailed 3D roadmap from CT is essential for guiding minimally invasive procedures in cancer patient. Now, the CT can be helpful in many ways in cancer patients, but I restrict my talk only to the pain interventions. And so many things are going up now, like the percutaneous tumor ablation to reduce the tumor burden in the patient with liver metastasis. In case if it is solitary or two lesions are there, then the radiofrequency ablation has been done under the guidance of CT. Stereotactic radiosurgeries are done under the guidance of CT, and even the nerve block procedures alone in a complex anatomy. So now we know that CT sections, like in case if we cut it like this, so it is the transverse section. We cut it like this, it is the sagittal section, and in this way, it is the coronal plane. So these planes are very important to understand little bit about the CT CT images, and the CT gives the exact anatomical configuration of what we have in our body. So in case if you are well versed about the anatomy, the exact picture is reproduced in the CT image. So as you can see that this is the base of the skull, the bookish picture, and the exact anatomy is there in the CT image, and our target most of the time for the trigeminal and Gassarian ganglion is the foramen ovale. So this is the transverse plane. The transverse plane is cut, and the exact picture is produced. But unfortunately, this is not always true in a cancer patient of head and neck. So now the foramen ovale is not always easily visualized on fluoroscopy during Gassanian ganglion blocks, with reported incidence of poor visualization ranging from about 10 to 45%. And I believe that 10 to 45% is a huge number. So this can lead to prolonged procedure time, increased radiation exposure, and potential complications due to inaccurate needle placement. So have you ever think of that you have taken a patient of in your OT setup under the fluoroscopic guidance, and you are not able to see the foramen ovale, then what is next? What will you do now? Either the options are of to abandon the procedure, or what else you can do. So here is the answer that you can apply. You can do the block under the guidance of CT. In case if you are little bit known to the anatomy of CT, and it is easy, little time is taken just for the planning of CT. I will not go into the detail of each and every block. This is just a simple webinar just to sensitize you that even CT is also equally important than fluoroscopy in a cancer pain management. I'm not talking about mostly chronic pain, but in cancer pain, it is much more important. So here's a paper recently given in this Anesthesia Pain Journal in 2023, that computed tomography guided Gassarian ganglion interventions for cancer related facial pain in patients with complex anatomy, insights, and recommendations. And you can see that the huge tumors are there, and it is not possible to see the foramen ovale under the fluoroscopic guidance, and with these patients with the perineural invasion. So the paper says that the CT guidance is an effective and safe option for managing cancer related facial pain in patients with complex anatomy, resulting in a significant reduction in pain, high satisfaction rates, and no mechanical complications. Future research should aim to refine the role of CT guidance in multimodal pain management in this population. So now this is a patient, middle-aged lady with a left upper alveolus carcinoma. And you can see that the MRI revealed an enhancing infiltrating mass in the left maxillary sinus extending in the pterygopalatine fossa, left cavernous sinus, and Meckel's cave region. And we tried doing the block under the fluoroscopic guidance. We could not place any needle. We could not visualize the foramen ovale. And then we went through a subzygomatic approach under the CT guidance. As in the CT, you can see that this is the needle which is inside the foramen ovale, and this is the 3D recon image of the patient under the CT guidance. And the trigeminal nerve involvement usually occurs in buccal mucosa cancers, sinonasal metastatic lesions, and lymphoma. So we published this case report that the role of advanced imaging in Gasserian neurolysis in head and neck cancer with the skull base invasion. And we concluded that the CT guided interventions of foramen ovale can be labeled as a novel method of locating foramen ovale for precise percutaneous to the trigeminal ganglia in advanced head and neck cancers. Now, this also we all know about the anatomy of celiac plexus, splanchnic nerves, that it comes from in front of the aorta and in front of the aorta at the level of T12L1, and it disrupts the visceral efferents from the distal esophagus to the splenic flexure of colon. So the neurolysis with alcohol or phenol effective for about 8 to 10 weeks. And this is the bookish picture of celiac plexus and the splanchnic nerves at the level of L1, that the celiac trunk is visible in front of the aorta. But unfortunately, this kind of figure you cannot visualize in a cancer patient of abdominal cancer like pancreatic CA or a CAGB, in case of it is because most of the time when we get the cases, the celiac plexus is entirely encased. As you can say that it is clearly visible in a patient of chronic pancreatitis, but there is hardly anything you can visible in a case of pancreatic carcinoma. And there's hardly any spread. Hardly you can see that the drug can spread in this region because of the massive tumor. So we tried doing this case. We abandoned the celiac plexus neurolysis, and we did this splanchnic neurolysis in this patient under the guidance of CT. And even in splanchnic nerves at the level of T12, it is sometimes it is very much difficult even in a CT setup also. Just there's hardly any space you get from the crus of the diaphragm and reaching just anterior to the anterolateral region of the vertebral body. So the clear anatomy, the clear precision, and the good needle placement, the CT is the always it should be taken into consideration. Now, this is also one of the paper. This is recently published just in 2025. This is an original article in Indian Journal of Palliative Care. Computed tomography guided fluoroscopic guided celiac plexus neurolysis for pancreatic cancer pain, a novel comparative study integrating pain phenotypic and functional outcomes. So this paper says that both CT and fluoroscopic guided celiac plexus neurolysis provide effective pain relief in pancreatic cancer. However, the CT guided celiac plexus neurolysis is associated with significantly greater pain reduction, especially in patients with neuropathic pain features, lower complication rates, and better functional outcomes. So, pain phenotyping using LANS enhances the procedural decision making and supports a personalized approach to the palliative care in a pancreatic malignancy. So now coming to the superior hypogastric block, I'm not going into the anatomy that it is situated in front of the L5S1 disc. It disrupts the visceral efferents, effective in urethral pain, pelvic visceral pains, post prostatectomy, penile pain, etc., etc. So just coming to the case that a 68-year-old female patient, a case of carcinoma endometrium, post robotic radical hysterectomy, a mixed malignant Müllerian tumor, which is a very aggressive one with a bilateral DJ stent in situ, you can see that the patient complain of abdominal and back pain. So MRI spine has also been done, but it is not conclusive. And in a PET CT, you can see extensive bony metastasis in this patient. Uh, the patient won't be able to lie down prone, so we decided to do the block in the anterior approach under the CT guidance. You just put the markers over the just inferior to the umbilicus. You can just take the that whichever needle is going exactly in front of the L5S1 with the least damage to the other organs. And what we are using only the 22 gauge needle, so there is hardly any damage to the tissues, and this block is done after a proper bowel preparation. So this is the horizontal line which is given by CT, and the vertical lines come from the your marking. So planning is very important. So local infiltration was given with using 1% lidocaine to the patient, and you can see that directly the needle 15 centimeter 22 gauge or 20 gauge needle can come, and you can see the spread of the contrast in front of the L5S1 disc. So this is the sagittal section showing the spread of the contrast, and the persistence of dye was checked. And this is a simple 3D recon image of the needle in front of the L5S1 disc. The persistence of the contrast is shown, and then later on you can, after confirming and giving local, you can you can do the chemical neurolysis using alcohol. Now, coming to the inferior hypogastric block, which is indicated usually in carcinoma, anal canal, rectum, vagina with perineal pain and radiation proctitis, you can see that this is the case that a 36-year-old patient, a case of Crohn's disease, post diversion loop ileostomy with rectovaginal and perianal fistula on biological therapy, referred to the pain clinic with intractable perineal pain of about 8 to 9 by 10. She had a burning pain which increases on sitting, lying supine. She was not able to sit, eat, and not able to take care of her small kids. Pain and urgency symptoms severely impacted her quality of life. And when the CT image was done and MRI was done, so MRI perineum showed revealed two sinus tract with external opening. In the right and the left side of gluteal cleft, extending into the anterosuperiorly in the ischial fossa, with joining at the anorectal junction in the posterior midline. You can see that these two tracks are there, and uh, when we perform the block, a simple ganglion empire block, there was hardly any distance from the posterior side in between the rectum and the anterior part of the sacrum. So CT gives the correct image, and within a very less space we could we were able to perform the inferior hypogastric block. Now there are few more cases, just to give you a glimpse of these cases, that these can be performed under the CT guidance as well. That a 48 year old lady with a CA rectum with bony metastasis, unable to stand post chemotherapy, radiation therapy, with severe backache, bedridden, no relief with oral morphine. And similarly, a male patient with a CA prostate with a sacral nerve root invasion with severe back and leg pain causing lumbosacral plexopathy. The huge mass is there encasing the lumbosacral plexus, and you can see that when we gave the caudal block, the needle is very nicely visible in the caudal epidural route. uh, Similarly, the RFA of sacral DRG for presacral soft tissue compressing the sacral nerve root, leading to severe radicular pain in a patient of metastatic carcinoma lung. You can see that easily the needle is approaching towards the sacral nerve root. So, as we know that in the patients of lower pelvic gynecological cancers, they have lymphedema as well. In a patient of carcinoma cervix, carcinoma endometrium, and for these, or in case if the patient has, this is a patient of CA with peripheral vascular disease, so we can even do the lumbar sympathectomy. These are the studies in favor of lumbar sympathectomy for lymphedema. So we can even do lumbar sympathectomy in these patients under the CT guidance. So advanced techniques are also there, like placing the port or intrathecal pumps in these patients. So this is a young lady of 36-year-old with a carcinoma breast with extensive bony metastasis and severe pain in the back. So we did the intrathecal port implantation, and you can see that nicely the catheter is visible in the intrathecal space. So, multimodal team-based approach in a young patient of metastatic carcinoma breast with extensive metastasis, advanced disease, and severe intractable back pain, intrathecal port implantation can be done with excellent pain control. What type of block is required, or what type of imaging is required is depends upon the individual who is doing the block, who is managing the patient. But still, my perspective is this, that this modality can also be taken into consideration for better outcomes and less complications. Now, what the evidence says that in case of complex anatomy, the visualization definitely it is higher in CT, which is limited in fluoro. Pain relief and functional outcomes in cancer pain is better in these patients, and it is even good in fluoroscopic also, but it is less robust. Complication rates are really, it is much more lower, because you can see in a 3D dimensional images, and operator radiation exposure is also lower, and patient radiation exposure is also variable, and it is even used in obesity and altered anatomy, and the fluoro it becomes quite challenging. So the pyramid of modern approach to cancer pain is, we know that chemotherapy, radiotherapy, all the anti-cancer treatment is required, analgesics are required, opioids are required, but interventions also play a major role, and nursing and psychological approaches also plays a major role. And we should never forget the biopsychosocial model of pain. We should try to do it with a multimodal approach, and with least complications, because these patients are already suffering a lot, and their psychology also has a bigger impact. Even the family also suffers a lot. So we should have to weigh and balance. And one more thing I just would like to add, that you must be thinking that the cost under the CT will become very high. It is now since 11 years by now, but we are charging the same cost what we have to pay to the fluoroscopic department. The same cost is for the CT as well. So it is not very much a costly affair as well. So cancer pain is multifaceted, and it is never static. It never goes linear like this. And as I told you, that always think of a biopsychosocial model as well. So pain in cancer survivor should be screened at each step, and not be treated same as the advanced diseases, like giving morphine to these patients. CT provides precise anatomical delineation, as we have shown in our pictures of few cases. Real time visualization is very important, and reduced radiation exposure. This is by the National Institute of Health, which says that CT guidance significantly reduces radiation exposure to the interventionists, and even to the staff, compared to the traditional fluoroscopy. So these are my references, and thank you for your patience.
Thank you very much, Dr. Pablesh, ma'am. That was an excellent overview over the CT guided interventions, especially in the cancer pain. So now I'd like to open the forum. If there are any questions, so doctors can put their questions in the chat box, and you can ask Madam about them. So I have a few questions, ma'am. I think I'll first start off with my question. Basically, in cancer pain, we see a lot of these pain syndromes which are there. So, if you have to make a choice, which cancer pain syndromes do you think benefit the most from CT guided interventions compared to fluoroscopy or ultrasound?
Mm, so many cancer pain syndromes are there. Like sometimes what we have seen, Javed, is like for the head and neck cancer, there is a brachial plexopathy is also there in these
Yes,
patients.
yes, correct.
So for these patients, ultrasound is a very good choice. That is very right. Fluoro, I'm little bit skeptical
Mm.
because the things are not very nicely
True.
visible, and so many times even in ultrasound also they have massive mass, and that even sometimes erodes the vessels and all these nearby structures also. So I feel that the exact anatomy, in case if we can take it under the CT guidance, we can do the hybrid technique as well, that
Yeah,
ultrasound along with the CT guidance, which can give you a very good result.
yes. No, I think that's a wonderful approach to mention that when the anatomy gets distorted, it becomes very difficult, especially in these kind of patients. And compared to other patients doing interventions in a cancer patient, I think it's a totally different ballgame. So definitely, I think that is one take-home message also, wherein a combination, as you rightly mentioned, can be done between CT and ultrasound. So we have a question from the audience, ma'am. Dr. Shri is asking, ma'am, could you please explain the radiation safety precautions which you follow?
Uh, there is no radiation exposure. This is because you take a cut, you go outside, you do the planning, you do the check the image, and then again you come inside, and then you manipulate your needle, and then again you go out. है ना? So there is no radiation exposure during this doing the blocks under the CT guidance. So we do it under all aseptic techniques, and we give the lead aprons to the patient, and we don't wear lead aprons in this because there is no exposure. All the time when we are taking the image, the room is closed, and all the console areas are radiation proof areas, so there's hardly any radiation exposure in this.
Rightly said, ma'am, that the radiation exposure is very less because you are in and out during when you're passing the needle. So, but still, are there any safety checks which are very mandatory before performing any CT neurolytic blocks? Any safety checks?
uh, yeah, but see, Javed, still in a CT setup, you always you have to keep your this emergency cart
Yes.
along with you, है ना? And when we perform a trigeminal or a Gassarian ganglion neurolysis, we always keep oxygen standby also,
Mhm.
because you don't know when the bradycardia is there or when the patient has this thing. So all these safety precautions which we do it under the CT, under the in the OT, minor OT or in the major OT, we have to keep it there itself. The emergency cart, the oxygen supply,
Yeah.
monitor, the IV fluid, everything. And in a cancer patient, sometimes the safety margin is very less because they have been suffering since years together.
Mhm.
There is a very fluctuable BP, and vitals are most of the time they fluctuate. So you have to keep all the monitors and everything just like a OT, but the dusty setting of this thing, USG or CT, that is
Mhm.
only changed.
Yeah. Correct.
I hope this answers the question.
Yes, yes, definitely. Another question, ma'am, which we have is they're asking about one particular, I think, case which you had showed. Could you briefly explain about the intrathecal port, which company you used and for how long it can be used? They're asking about the intrathecal port, I think, which you had shown. Yeah.
This is a Medtronic company port. Actually, when we used it, even the company also didn't know that we can use it for this purpose as well.
Mm.
So we specifically told them that we can use it even for this purpose, and we implanted the port over the abdominal wall in the patient. That went at least for about 2.5 to 3 months, and then the patient passed away. But till the end, she had a very good pain relief, and she was able to do her activities. And this is a very small port with a very small volume. It is not like a proper intrathecal pump, because the cost is also very less.
True.
So the volume is very less. We educate the patient with the special needles that uh, they can themselves, under the full aseptic technique, they can put the drug on their own. We give them the drug, we educate them how to use, how to prick that port inside, or maybe the caregiver of the patient. And then in case if we see that the family is also conducive with everything, the environment, then we use such kind of ports,
Yeah. Hope that answers the
which
question.
is a economical thing, because we cannot put so many expensive devices in a cancer patient.
Agreed. Agreed. Too, because financial
Yeah,
is a very
implications are
important
also, yeah.
point to keep in mind. Next, we have an interesting question. Dr. Khalil is asking, is there any special risk for interventionist who is having autoimmune thyroiditis? So that means the doctor is having this condition.
uh, Not exactly. Means because we don't have a radiation exposure in this,
Yes.
we are all the time, we are going out whenever we take a image. So I don't think so that there is any problem even to the doctor. And this is not, I'm telling, this is by the National Health Institute, that they are saying that the radiation exposure is very less, the complication rates are very less. So we can easily, it is little bit in the beginning, it is little bit time consuming when we are doing the planning, but later on over the years you expertise in this, and it becomes very fast, and the time also taken is very less.
Correct. Correct. And if it is a fluoroscopy, then is there any safety protocol, ma'am, for autoimmune disorders?
mm, I'm not very much, well, you can use this neck shield, yeah, that is important.
That is the most
And in
important.
this, we are not wearing the lead apron, so we are
Mhm.
not wearing that, even the neck shields also in CT.
Agreed. Next up, we have a question from Dr. Hassan. So Dr. Hassan is asking, why does interventional pain medicine for cancer remain underdeveloped in many healthcare systems? And what strategies are needed to strengthen, support, and expand its integration into oncology and palliative care? So strategies to integrate pain and palliative care into oncology and palliative care. I hope that is a question. Yeah.
This is a very tricky question, Dr. Hassan, but still, more and more awareness is required, education is required. It is not underdeveloped in India. Globally, it is underdeveloped. And it is, the patients of cancer are undertreated. Why they are undertreated? They are undertreated because of the lack of knowledge, the lack of staffing, um, the lack of education and training. So at all these levels, and one more very much important point here is the opiophobia. The healthcare professionals, they do not want to use opioids, because they are afraid of so many things. Even today also, despite so many good guidelines and so many easier steps to get a license and get the opioids, but still people are hesitant. They can use a lot of diclofenac confidently, but they cannot use morphine. So lack of awareness, lack of education, lack of training at each and every step is there. But what we can do, uh, how can we improve it? We can educate more and more people about it. We can talk about it. And like, suppose now we are there, at least 20 people are listening to this, because it is easy, little bit it is easy to do the spine intervention, but doing a cancer pain intervention is really a different ball game. It is not at all easy. You have to take into confidence the medical oncologist, the surgical oncologist, and above all is the patient and the family. And it should always be a personalized patient approach. Whatever the patient requires, whatever their wishes are there, we should do accordingly. So I think more and more awareness, in case if from 20 people here, one can also go further and spread the awareness. So like this, it will take years together, and since our seniors are also have done since 2 decades by now, but still the cycle must go on.
Yeah. Awareness and teaching, I think, is the most important thing,
Yes.
which is the theme
Yes.
of our webinar also today. Right. So one question which is coming to my mind, ma'am, how important is contrast spread pattern in confirming the correct needle placement in case of a CT intervention?
Very beautifully seen. Contrast pattern means whatever wherever you are giving the contrast, like it is very important for us the celiac plexus, plank neck, and even superior hypogastric, है ना?
Yeah.
Because so many vessels are there nearby. In superior hypogastric, iliac vessels are there, here aorta is there. So so many important structures are there, and a very nicely a good spread. And along with the spread, this, whether the spread is sustained or not, it is very important. So give some time, and just see after 2 3 minutes that whether the contrast is nicely there in the place. And then first try always with local anesthetic, and then only later on go with a, after 8 to 10 minutes, go for alcohol.
Agreed. I think very true. So, other thing which we have to keep in mind is, are there any complications in CT career interventions which we have to keep in mind so that we are prepared with it, ma'am?
Implications are there. Even we have seen cases of paraplegia also,
Mhm.
after this CT guidance, celiac plexus block under the CT guidance.
Okay.
See, how you are doing the block is important. How
Agreed.
you are able to correlate your images are important. And
Mm.
the spread of the contrast, whether it is getting sustained or not, this is also very important. And what the patient is saying at that point of time, sometimes they have lot of burning sensation. As soon as you give, the patient complains of burning sensation. Just
Yes.
check that whether your needle is in place, or sometimes while giving the drug or local, it becomes somewhere the position is sometimes altered. So just always be patient, check the needle placement at each and every level, and get well versed with the anatomy. In case if you are strong in anatomy, the CT anatomy is also equally correlates with the human anatomy. Or we can see so many things nicely in a three-dimensional picture. So definitely complications are less. But in case if we do not see the nearby structures, we do not see that the
Yep.
patient is complaining of pain, then it might lead to problems as well.
True. Very true. In your cases, I think the cases were very interesting for all of us to go through them, and most of them, the cases which were real life cases which you have done, you had put up in a presentation, ma'am. Thank you for that initially. One thing which I wanted to ask you is, what technical tips would you suggest to avoid organ injury? Because we are seeing organs close by and the needles were going through. So, any technical tips to you would like to suggest to avoid organ injury during CT guided procedures?
Like Javed, like in case if you are doing a superior hypogastric access block,
Yeah,
so for that, bowel prep is very much important,
yes,
that patient. And
correct,
what we are using is, we are using only a 22 gauge needle. So
correct.
with that simple 22 gauge needle, in case if we are we should not manipulate it na, like to and fro like that. Simple, straight, your marking, your planning is very much important.
Yeah.
Just plan it, just go through that needle which corresponds to the in front of that L5S1.
Mm.
Just go straight with a single this thing. It is very easy with a anterior approach. Single needle can do the thing. You need not put two three needles in that. There is
Oh,
no transdiscal approach or nothing. Just you go, hit the vertebra, just withdraw a little bit, give the contrast, see the persistence of contrast, and then just give the alcohol. So these are the important things. Always come into your mind that for these lower abdominal patients,
yeah.
you have to keep the bowel preparation ready. For in case if you are doing anything celiac plexus block, you have to give hydration to the patient before performing the
Yeah.
block. So these basic things what we do in our daily practice, and hygiene and aseptic precautions are very much important.
Very true. Very true. So I think I think have time for just few more questions. No, one question which I'd like to ask you, ma'am, is that usually is there any particular level of training required to practice CT guided procedures independently? If yes, then where can these trainings be done? There's a question in the chat box also. Whom they're asking in Hyderabad, is there anything fellowship in palliative care? So, is there anything like specifically doctors should get trained for CT procedures? Or
Yes, definitely. Because see, how to put a marker, which marker is adequate for which block, and
right?
how to get that horizontal line and the vertical line, the transaction of which we use for as an entry point. So
Mm,
definitely, the learning is required. The positioning is important.
yeah,
The markers are different for different kinds of block, and for training. The people who are doing the CT guidance, the blocks under the CT guidance, you can approach them. And we do also conduct the palliative care and pain workshops and training. And you can approach Dr. Javed, you can approach me anytime, in case if you want to learn. Because cancer pain is different, as I told you in the beginning, from the
right.
chronic pain. So I think the younger generation is much more interested in chronic pain rather than cancer pain because it is something little bit complex and little bit dicey. But still, giving a pain relief to a cancer patient, it gives a alag type of happiness to you.
Bilkul,
And
bilkul.
you will be just happy.
Yes, yes, definitely. I think can vouch for that fact because chronic pain, chronic cancer pain, I think is one particular thing wherein expertise of anesthesiologists, those doing interventional pain training, I think they are the ones who will take care of these patients because it is very important. Even in most of the places where you go to work, also, if you're seeing cancer patients, then learning more about cancer and interventions is very, very important. So I think one more question I'll take, ma'am, before we conclude. In ascites, can we use CT guidance? Dr. Samir is asking this question.
In case of ascites is there, which is usually there in abdominal cancers, we tap the ascites and then only you can perform the block. Because in case of ascitic fluid is there, you cannot see anything in the ultrasound. Patient will not be able to lie down prone for CT guidance or for fluoroscopic guidance. So it is always better to tap the fluid. How much is the minimal required fluid which we can take it out, because sometimes these patients are in a hepatorenal syndrome or the BPs are crashing. So take a minimal of 1 liter of fluid, counsel the patient, and then only you can do. In case if the patient is able to lie down prone, then you can do it under the CT guidance.
Great. So I think we are coming towards the closure of this webinar. I think it was a wonderful session, ma'am. And basically, the webinar was very much real world connection because of thanks to the cases which were there. And I'm sure it has sensitized the candidates about the importance of CT. So before I leave you people, before we leave you people, just a small announcement which we would like to make. Uh, we have the Algos Academy of Medicine and Prayatna Care Pain Medicine Clinic collaboration, integrated palliative care course for doctors. So this is an online program wherein we have a host of expert faculties who will be teaching about cancer pain, chronic cancer pain, and palliative care as well. And as ma'am was rightly mentioning, in today's day and age, chronic pain interventions definitely you have to know, but chronic cancer pain interventions, I feel you have to know even more better, because that is where your expertise is actually required and where we have to learn. So be it CT guided training procedures, or be it chronic pain interventions, cancer pain interventions, I think this course is designed for doctors who want to take their cancer pain level expertise and training to the next level. So if anybody is interested, you can feel free to contact us and we'll be sharing you all the details. So, with this, I'd like to thank Dr. Bablesh Mahavar ma'am for taking out her valuable time and giving us in a very simple way about the expertise required in CT guidance in cancer pain procedures and interventions. I'm sure Madam has covered the topic really well and made it really interesting for doctors, that those the I would say the things, the lacunae with fluoroscopy which were there, we have CT to actually cover it now. A few last words from you, madam, before we conclude.
Um, Actually, cancer pain management is basically the amalgamation of pain management, palliative care, the management of patient and the family. And in case if we are following the policy as do no harm to the patient, because already these patients are suffering a lot and they are in usually in financial crisis. So give your best to the patient with proper visualization of the structures in case if you are putting the needle, and always remember the biopsychosocial model of pain, and always give most of the time the conservative management, have no opiophobia or that's all. So, in case if you would like to go more into detail, because as chronic pain is different from cancer pain, similarly, palliative care is also very much different from all this pain management. So, in case if you would like to learn more further, you can definitely approach us. Yeah.
Thank you so much, ma'am, for the wonderful take-home message. So I'd like to conclude today with our webinar, but leaving behind one particular point, that we've recorded all of this, and the recording will be available soon